Hello, welcome to the New England Journal of Medicine. I'm Dr. Terry Schrader. On December 27th, the journal published a perspective article written by Drs. Arnold Milstein and Tom Lee entitled Comparing Physicians on Efficiency. I'm with Dr. Lee now to discuss those issues in further detail. The purpose of measuring a physician's efficiency, besides cost issues, really is what?
Well, I personally feel that efficiency is just one more dimension of quality. Of course, the real measure is to help spur improvement. If people know that they're doing worse than average compared to their colleagues, then that should, in theory, lead them to look at their practice, get some help, and try to get better. That's the theory. Now, in reality, we know that when people see data that don't look good, they have a tendency to resist it. And in the past, that happened most of the time, frankly, and so a lot of data got measured and didn't get used. But now what's different about these times are we've got an unbelievable economic crisis in this country. Today, affordability of healthcare is a middle-class issue. What we're finding is that people making what we've always considered good salaries, $70,000, $80,000 a year, are having trouble paying for their health care. So suddenly everyone is really concerned about the cost of care, and patients are having to pick up a lot of these costs. And as they pick up these costs, there are really two questions that come up. The first question is, what am I getting for what I pay for? That's a fair question. And the second question is, if Dr. A costs a lot more than Dr. B, or Hospital A costs a lot more than Hospital B, is one better than the other? And if not, maybe I should just go to the lower cost doctor or the lower cost hospital. New insurance products have come along that put me and other physicians in different tiers based upon how efficient we look. So that if Tom Lee is very efficient, he might be tier 1, and you might have a very low copayment if you choose me to be your primary care doctor or come see me as your cardiologist. On the other hand, if Tom Lee is not so efficient or not so high quality, I might get put in tier 2 or tier 3, and you might pay more to come see me, or Tom Lee might get excluded from your network altogether, and you might not have the option of seeing me at all.
Could you share some of your own data with us? How does Dr. Tom Lee look in terms of your own care of your own patients?
Well, it's a pretty good but not perfect report card, and which I think is a reflection of reality. I think in the big picture sense, I look pretty efficient. My percent generics are about 75, 76%. But there are areas where I have high CT use. I didn't know I had high CT use until I saw the data recently, raising the question of how am I using CT of the back and the shoulder and the knee, and I should be talking to some of my colleagues and getting some advice on that. On the quality side, in general, I look pretty good, but about 20% of my diabetics have hemoglobin A1Cs over 9. Now, I've looked at each of them since I got those data, and there's a story behind everyone, and like my worst one has no insurance and he doesn't show up a lot, and in general they tend to be poor people with a lot of different issues. But that said, they're mine, and the performance reporting is highlighting to me that a good fifth of my diabetics have poor control, and I'm glad to know that because I'm trying to do better with them.
But how does that help the patient who's coming to you or the insurer who's using you? How does that data help them?
You know, the truth of the matter is, I don't really care. And because the truth is, patients don't really look at these data. I really believe the great thing about transparency is that it's a tool for helping providers get better. But I do think that there are many, many different ways of measuring efficiency that could be useful.
Can you give us some examples?
Well, some of them are very simple, and they've been around forever. And, for example, the percentage of my prescriptions that are generic, that's obviously just one part of medicine. There is no right or wrong answer. You don't want to go to a doctor that's prescribing 100% generics, but you don't want to go to a doctor that's prescribing 0% either. What's the right number? There is no right number, but I think if there's a bell-shaped curve of what the percentage generics is, that's what rational people are doing, and you're at one end or the other, that should tell you, maybe I'm being a little less efficient than my colleagues, and I should look at how I'm practicing. And if you're prescribing a lot more generics than other people, it should raise the question, maybe I'm a little out of it and missing out on some of the new drugs that might really benefit my patients. But that's just the simplest kind of efficiency data. The more complicated ones, the ones that the health plans are increasingly using, are where they take administrative data like all the different claims for doctor visits, hospitalizations, drugs used, tests ordered, and they analyze episodes of care, not just what happened during a hospitalization, but what happened during an episode of unstable angina, for example. And then they compare you on your episodes to other people in your specialty. And they can say, compared to other cardiologists, you seem to use more resources for a case of unstable angina than your colleagues. And then they can break it down saying, and you seem to be using less pharmacy, more radiology, more days in the hospital. They can actually do that kind of analysis. I don't think those kind of data are final. They're based on administrative claims data, which have their problems. On the other hand, I do think that they're probably more often directionally correct than incorrect. I think they're good enough for the beginning of a quality improvement process,